Welcome, everybody. This is Herpes A to Z for the eye care practitioner. This is Optometric Education Consultants National Webinar Series. And it's my great privilege and honor to introduce our speaker, my partner and friend, Dr. Greg Caldwell, who is a graduate of Pennsylvania College of Optometry, where he also completed a one-year residency in primary care and ocular disease at the Eye Institute in Philadelphia. He's a fellow of the American Academy of Optometry, a fellow of the Optometric Glaucoma Society, and a diplomate of the American Board of Optometry. He currently works in Duncansville and Johnstown as a medical practitioner in consultation in private practice. He has lectured extensively throughout the U.S. and other countries on diseases of the eye and pharmacology. He has been involved in numerous clinical trials. He has served as the president of the Pennsylvania Optometric Association and was a member on the AOA Board of Trustees from 2013 through 2016. He is president of the Blair Clearfield Association for the Blind. So with that, let's give a nice virtual welcome to Dr. Greg Caldwell, who will get us started and regale us about herpetic eye disease.
Thanks.
Greg, take it away.
Thanks, Joe, and thanks for the nice introduction and great working with you. And you're going to see Joe as the moderator tonight, as long as he doesn't lose his power from the tropical storm. So we're going to do herpes A to Z tonight, and we always have to start off with disclosures. And I think the most important parts for tonight is the content of the activity was prepared independently by me. No one company has asked me to talk about anything in particular tonight that's out there. So with that being said, you're going to see me reference, I guess, BioTissue or Prokera. And again, they have not asked me to do anything in here, but I've lectured for Alcon to OptiView. I sit on advisory boards from Allergan to Dompe. I do sit as the PA medical director for Involve, which is a managed Medicaid. I do sit as a chairman of the advisory council for diabetes for a healthcare registry. And then the next two bullet points are important here. I have no direct financial proprietary interest in any of the companies or products or services that I mentioned. And then the next one, again, is this is going to be presented without any commercial bias and does not claim any superiority of any commercial product that is mentioned. And it's a pleasure to be partner and half owner with Optometric Education Consultants with Dr. Salka. With that being said, here is the course description and learning objectives. And it's in the handout, so I'm not going to really read this. The key is that, herpes viruses are common infections, and I'm going to cover a wide array of clinical pearls. As Joe mentioned, I do go into two practices, act as a disease consultant, and do see herpes a lot, or it gets punted to me a lot because people just don't like to treat it. So with that being said, we're going to do the first polling question that's out there. And the first polling question is, how many herpes viruses infect the eye? And with that being said, I can see Joe has launched the handouts in the chat box, so they could be there. So how many herpes viruses infect the eye? Is it 2? Is it 3? Is it 5? Is it 8? Is it 10? Or, hey, I don't know, and that's why I'm here. All right, I think that's a pretty good amount
we're
of
doing
people.
quite well.
So we'll share the results, and we can see here the majority of us say 2. So let me jump in, and the oral viruses that affect the eye, or the oral medications that can be used, are Valtrex, acyclovir, and Famvir. But I think what happens when we start talking about oral medications in herpes eye disease is we forget about things like Neurontin and Lyrica, doxycycline, and L-lysine, and the tricyclic antidepressants for the neuropathic pain. So some of the fun facts, and the reason why I launched that poll early is so that people didn't look ahead and check out the answer. But, the fun facts about herpes, it's the leading cause of human viral disease, only second to influenza and cold viruses. I'm not sure if how that stacks up to the coronavirus, but pre-pandemic, it's only second to the cold or flu viruses. Now, there are more than 130 herpes viruses that have been identified. And how that came about was I was at a lecture one time and someone said, "Hey, my dog's got herpes. Can I get that herpes?" And I'm like, "I don't know." So I started researching. The answer is really no. This virus doesn't cross over. And there's been 8 of the 130 that are out there, and there might be more now, but there's 8 that infect humans, 9 if you break number 6 into 6A and 6B, but there's 5. The answer is 5 that affect the eye, and that's herpes simplex 1 and 2, the zoster virus, the Epstein-Barr, and the cytomegalovirus. Now, everyone in here probably sees patients or saw patients at one time, and probably everyone in here would test seropositive for the herpes virus. So you check the antibodies, everyone would be seropositive because this virus is everywhere. And you can see that there's a statistic that in the United States by age 4, 25 or 1/4% of the population tests positive. So this virus is, very common. It hangs out in our body. And again, here are the 8 human herpes viruses that affect humans. You can see that they can label them as herpes human or human herpes virus number 1 through 8. Number 6 can be split up into A and B. But you can see here, the ones that we're familiar with are herpes simplex 1, 2, and zoster. And then I've kind of grayed out the other ones over here on the slide on the right. And you can see that the Epstein-Barr and cytomegalovirus affect the eye, but they kind of affect it in a different way. And that's really what this is about. And this is how they're classified. If you look at the 5th column over right here where it says latency, you can see that the herpes simplex 1, 2, and zoster are neuronal viruses. They hang out in the neurons, the nerves, right? When it affects the eye, it's the trigeminal nerve that it comes down through, most likely the ophthalmic division. And it kind of takes on that classic pattern because those are neuronal viruses, these top 3. But you can see here that the Epstein-Barr virus hangs out in the B lymphocytes, and the cytomegalovirus is monocytes, lymphocytes, and potentially some other cells that are a part of the immune system. And that's why they take on the certain patterns, or that's why you'll get the retina complications that you do, because it's not really coming through, it's coming through the vasculature rather than coming through the neurons. And that's why we get the classic patterns whenever you have the trigeminal nerve. So what about herpes simplex? Why is it important? It's the leading cause of cornea blindness in the United States. And I say that all the time. I say that to the patients and I say that to the practitioners, that I didn't say third world countries. I said it's the leading cause of cornea vision loss, cornea blindness, cornea vision loss in the United States, primarily due to the herpes simplex number 1. But we're going to see here that, there's been so much cross-contamination, for lack of a better term, that it could be herpes simplex 1 or 2. And there's really no clinical value of knowing it because they're both, equally weak when it comes to identifying and getting the right treatment on there. The keratitis nomenclature that's out there is, the epithelial keratitis. That's your classic dendritic. Then you have stromal keratitis, the endotheliitis, and then you have neurotrophic keratopathy, which is a serious complication. And luckily, in the last year or two, Oxervate has come along to really help us with these patients to treat this. And this is a very busy slide when you look at it, but it's talking about herpes simplex 1 and 2. And you can see that, they've tried defining that it's conjunctivitis and then the different types, above the belt, below the belt. They've done enough testing here that, you can get herpes simplex 2 in the eye. So it's just not related to below the belt. A large population does get type 1 in the eye, but you could still get type 2 in the eye. And again, there's really no clinical value of knowing type 1 or type 2 because the viruses, there's no clinical value to doing a culture because they both respond to Zirigan or Viroptic or your oral medications really, really well. So this is what happens a lot is these dendrites come in, you get this great diagnosis that's out here. And you send a prescription over for Ziragan or to Veroptic, and the pharmacist says, hey, you know, I really can't get that. And you can see this one's centrally located. This is right on the visual axis. And this is, you know, a leading cause of corneal blindness in the United States. So what do? Well, one of the things, and we can use, this will be a good example for the chat box. I work, as you know, I lectured with a pharmacist, and Tracy at one time just said, hey, just tell the pharmacist what you want and pick a pharmacy in town and ask them to keep it in stock. So right down the road, I have this Duncansville pharmacy, and they're great. And I always ask them to keep 2 medications in there. I'm just kind of curious if you guys have a chat room, what might be put in the chat box, what would be one that I'm missing. But I always ask them to keep Ziragan, 1 bottle or 2 bottles in stock, and 1% atropine. I ask them to keep, you know, those 2 in stock for me at all times, because when this walks in, I like to cover this with a topical medication. Now you'll see when I get towards the end that you could just use an oral medication on this. So if someone came in and just had this dendrite, there are some evidence out there that you can just go orals only. When it's centrally located like that, I don't like to do orals only. That's just my personal preference. I like to do orals and cover them with some type of topical like Ziragan or Veroptic that's out there. And in some cases, I'm starting to see that haze. It might have been there for 3 or 4 or 5 days, and you're starting to see that stromal haze. I will use an amniotic membrane that's out there. So with that being said, I'm going to launch the next poll. And with that, the poll says, have you ever used an amniotic membrane to treat an infection? And if you did, was it dehydrated, cryopreserved? Doesn't matter, dehydrated, cryopreserved. Or I didn't realize, and now maybe I will. I don't see any other medications out there anyone's using. I'm watching the chat box. So one, again, my clinical pearl would be to put, you know, to ask your local pharmacist, keep 1% atropine for those nasty iritis, you know, those ones that are going to be synechia to that anterior surface of the lens. It's nice to have atropine on board to treat those iritis. And I like to keep Ziragan around. All right, looks like the polls rolled in nicely. So we're going to share the results. And you can see here a majority have not used an amniotic membrane, so something to consider, especially if it's the leading cause of corneal blindness. You start getting that central haze or that central development. And I see here that you know, a few people have used both dehydrated, cryopreserved, and some just cryopreserved and dehydrated. So good. So, you know, herpes simplex, you know, the infectious epithelial keratitis, the stromal keratitis, endotheliitis, you know, it's pretty much the Prokera will work on that infectious keratitis. You don't really need it for maybe stromal if you're getting the haze, but the endotheliitis, but the neurotrophic keratopathy, it kind of falls in. So it kind of touches, you know, on a lot of those, maybe not the endotheliitis that's created by the herpes simplex. Now, this is what I did want to show here is that this is the package insert. And, you know, I read a lot of package insert being a speaker. And I remember going to a conference and, you know, being talked to by the representative of these different membranes. And, you know, they gave me one, or I bought one and brought it home. And I, you know, let me read over this and put together an amniotic membrane lecture. And if you get down here to the bottom right-hand corner of this first page, and I blew it up here where it says general usage. You know, remember, this is dehydrated, and it says it is intended for wound covering. And if you jump to the next page up here, it says not to be used in an active infection. So I guess, you know, the biggest caveat or the biggest clinical pearl that I can tell you from the dehydrated membranes that are out there is that they all have this precaution on there that are not to be used for an active infection. And remember, this is an active infection, this keratopathy or this herpes simplex keratitis. It's an active infection. So I just throw it out there, and just in case, you know, this ever goes south, and then someone ever says, well, why did you ever use this when it says that it should not be used in an active infection? And you can see here that it's called wound right here, wound covering. And I'm sorry that I didn't get it, you know, kind of sloppily as I was circling all that. The cryopreserved, which is the Prokera that's out there, it's a different animal even by the FDA. It's, you know, biological Band-Aid that's out there. And if you read this long drawn out paragraph, it is actually okay to use the cryopreserve for an active infection. It actually is kind of indicated that's out there. So I just wanted to throw out there is, you know, please, you know, read the package inserts. Treating bacterial ulcers, you can use an amniotic membrane. You could use it for herpes simplex, but just know that one says it's not really should be used by looking at the package insert. The wording, you know, is not intent, it's wound covering, and it should not be used in the presence of an active infection. So you decide what you want to do with that information. So this is just a really good example. 51-year-old man was referred in. You know, it said for treatment or potential amniotic membrane. I just switched it over as a reminder to make sure that we use a cryopreserved membrane on this ulcer. It's been using Ziragan 5 times a day for 5 weeks. Then Valtrex was added 1,000 milligrams 3 times a day. And then there was a steroid added, and this wound just would not close. You know, so at this point, you know, I would probably still cover it with an amniotic membrane. I would check the cornea sensitivity. And then at that point, consider ordering Oxervate, which is going to be, you know, a 2 to 4 week process. So we're going to want to do something before the Oxervate would come in for this patient. So we talked a lot about herpes, you know, simplex. You know, this is an A to Z type of presentation. So I do want to talk about the Zoster virus. Now, between the two viruses, the Zoster virus and the simplex, this one's a little bit more robust. It's not as wimpy. The simplex are wimpy. They respond quickly if you can just identify them. And sometimes that's the trick. You know, is it just a wound gap, or is that truly a dendrite, so on and so forth that's out there. But the zoster, you know, you want to identify, and this is really, and I have another case, this is really where you want to identify it. This is where you can really help the patient by getting them on that 1,000 milligrams of Valtrex or 800 milligrams of acyclovir 5 times a day, or the Valtrex 3,000 milligrams 3 times a day. And remember, it comes through the trigeminal nerve. So it's in this case here, it's the ophthalmic division. And we all remember where the cheek is, that's the maxillary. And then where the jaw is, that's the mandibular division of the trigeminal nerves. There's 3 separate branches of that trigeminal nerve. And this is really the funnest time to really catch this. And this lady came in, and, you know, she had that, feels like there's, you know, bugs crawling on my face. You know, my face is starting to get a little puffy. And I really didn't get the diagnosis until I was kind of poking around. I pushed the slit lamp away because the eye was fine, started checking out the swelling around. Then as I started pulling like the hair back and checking this out, this is the lesion right here that really classified of exactly what was going on. And if you look right along this hairline, you could see it almost just looks like if I would put some sodium fluorescein on that, how that would look like a classic dendrite. You could see how it's branching. You could see the redness. That would be like, say, some swelling around that on the cornea. And this is when I said, oh, this, you know, this is Zoster, or this is a herpes virus coming through that trigeminal nerve. And we're able to catch this really, really early out there and get this patient treated before, you know, they go into that big inflammatory reaction. And, you know, there's patients that come in that look like this. You can see that they're later in the disease. And you can see this patient on the left here. They have some open wounds. Sometimes you might want to cover those just with some antibiotics that are out there. So the vessel of the tip of the nose tells me that the nasociliary is involved. You can see here. And, you know, I walk out my patients, and I walk them to the front, and I'll see the patient that's in for the zoster. And, you know, they're usually on my schedule. So I'll go walking by. And as I'm walking by, you know, I'll just give them some words of encouragement. Hey, looks like we need to see you today, and that's why you're here, and we're going to take care of you. But what I'm talking to them is I'm trying to see if the tip of the nose is involved. because if the tip of the nose is involved, there's a good chance that the eye can be involved. And if we go back and we look at some of these patients, the tip of the nose is involved. You can see her eye is nice and quiet. Tip of the nose is not involved. His eye is nice and quiet. So that's one of the things I've learned is that, because when the globe starts getting involved, that's more of a risk, because remember that zoster is a little bit more robust. Now, I should have put this in as a polling question, but I just thought of it now. How many times, ask yourself, have you had a patient come in? Maybe it looks like this patient here, and the primary care doc has already put the patient on 1,000 milligrams of Valtrex, and maybe like a Medrol dose pack, right? And they send them over to you, and you're like, okay, what the heck? You got herpes zoster and you're already treated. Talking to the primary care docs out there, the reason why they're sending them to you is because when they went to school, they learned that, herpes zoster virus can create an episcleritis, scleritis, keratitis, uveitis, iris atrophy, glaucoma, vitritis, retinitis, choroiditis, optic neuritis, and cranial nerve palsies. So even though they're sending to you appropriately treated, what they want is a good dilated exam, checking out anything that can be affecting the episclera or the sclera to the cornea, to the anterior chamber, all the way back through the vitreous to the retina, to the optic nerve, and then the mono neuropathies 3, 4, and 6 that can be occurring. So what they want when that happens is a good dilated exam and a nice report back, knowing what the findings are. So don't feel like, they're trying to challenge you or what the heck's this person on there. I get that question a lot whenever I lecture, and, working with primary care docs and ask them that question. This is what scares them, and they just want to make sure, they got the disease diagnosed. They just want to make sure that the patient isn't going to lose vision. So that's what they're asking for. So polling question number 3, when you look at this lesion, is it a herpes corneal infection? So when you look at that, is that yes, no, I don't know. So if anyone wants to put some thoughts in the chat box out there, if you're not sure, like what are things that you can do? There, you can see that there is some fluorescein in the eye. You can see it's very faint. You can see I don't really have on the cobalt blue filter, but this isn't lighting up like some of those classic dendrites that you see. And I had a sneaky suspicion that this was some type of herpes infection. So I'm going to turn off the poll. I'll share the results. And we can see here that, a lot of people, I just don't know. So, what's a testing that you can do for this patient? And one of the things I've learned to do over the years is cornea sensitivity. And there's really no fancy way that's out there to do it. I forgot to bring home my cotton tip applicator. I was going to kind of demonstrate it for you, but pretend I just opened up a cotton tip applicator. The wooden part is in my hand. I literally grab the top of the cotton tip applicator with my fingernails, pull it out, and then twist some of the fibers. And I'm going to show you here. This is this patient. I actually took a screenshot. I played this video and I screenshot a part of this video. So this is how basically you do a cornea sensitivity testing. This has saved me multiple times. This is the eye that doesn't have, you can see it's the right eye. You're going to see when I touch very slightly, boom, boom. You can see that's, normal cornea sensitivity. Now, this isn't like an anesthetic like fluorescent in the eye. This is just sodium fluorescein. And you can see as I put that on there, the patient is hardly feeling that as I drag that across. That's cornea sensitivity tested. And I'm going to play that again for you so you can see. You can see I've taken the cotton tip applicator, pulled the top off, made that little wisp. And as soon as I get in contact, boom, that patient is just jumping. Again, no anesthetic in this other eye, just sodium fluorescein. And this was helped me to solve that this was an early onset. Didn't have to be that classic. Look, I'm just laying that right across. Patients, yeah, I don't know, doc. I don't really feel anything. Okay. And then I showed them the video afterwards because I have a camera in my office and a video system. So herpes is the great masquerader. Yes, it is. So you're welcome for that, Pearl. Yes. So I'm going to done showing that. I'll play this, move on to this next slide. This is a 37-year-old woman. The right eye is red and painful. So 20/30 vision, you can see nothing really from the externals or from the correction. So when we jump in, this is that how old 37-year-old woman. And one of the first things I like to ask is this your first episode? And you're going to see that because that's how we're going to start applying the herpetic eye disease study number 2. You know, the diagnosis, I think, is pretty straightforward here. You could tell that this is just a nice herpes simplex. It's either 1 or 2 herpes simplex 1 or 2 dendrite. First episode. You know, your treatment, you know, Zirgan, artificial tears. How about a steroid? Sometimes, always, never. You know, at this point is not the time to add the steroid, right? I think we've all done that. Hey, I'm not sure what's going on. I'm going to put you on, you know, doctor in a bottle, some Maxitrol. You brought the patient back the next day and you go, oops, yeah, I know what you got now, you know, because there's now 6 dendrites on the cornea that are classic. You are going to need to add a steroid probably to a lesion this big at some point, but I don't add it until I get reversal. So we're going to start off this patient by Zirgan, artificial tears, maybe 4 or 5 days down the road, adding a steroid. But how about an oral anti-herpetic medication? Just ask yourself that question. Is it time? You know, consider it long-term. No, I don't think you have to because this is the first episode and that's why we're asking that. Now, do I put my patients on orals? I do it quite a bit because what that helps me do is reduce that viral load. And I can tell you, if this wasn't centrally located, I might just treat this peripheral with just orals only. The orals are that safe. Another reason that you could do is it was failure to respond to the topical treatments. And another reason, again, is goes back to that original slide or one of the earlier slides that I talked about, where I was talking about you called the pharmacy up and they can't get it for 24 to 48 hours. This is something that you would consider putting the patient on orals for sure. Now, we can treat these pretty easy. The herpes simplex is a pretty wimpy virus. It's resolved. And maybe we just finish with a steroid with this patient. What's the chance? Ask yourself, what's the chance of this recurring in the next 12 months? This is important to educate your patient. And I educate my patient every time I treat a herpes simplex and it's resolved. You can see the eye resolved nicely. And I say to the patient, hey, look, you did great. You listened to, you took the drops, your cornea recovered, leading cause of cornea vision loss. You didn't have any of that happen to you. However, there is a 25% chance that this can come back in the next year. Why is that important? Because what is the last drop that you used for this patient? The steroid, right? So that's what made their eye feel good. So you want to make sure that they know there's a 1 in 20, 4 patients that you treat, one of them are going to come back, 25% chance they're going to come back. And the last thing you want them to do is self-medicating with that steroid. Now, another cranium keeper that's out there is Viroptic. How long should it be used? You're using 1 drop every 2 hours up to 9 times a day or 9 drops a day. And if you read the package insert, it says 21 days via the package insert is really the max that you should be doing it. And the reason why I bring it up is because of this picture here. This is not the greatest picture that I have because of this, but this is a picture of a patient that was sent to me because the herpes simplex was not resolving. This really isn't herpes simplex, right? This is just a keratitis. Now, sometimes they can be a little trickier because you kind of get that wound junction where that wound closes and it looks kind of like a pseudo dendrite because the way the epithelium heals. And so the docs will look at it and go, man, I just can't get this dendrite to go away. And it's really not a dendrite, or this is more of a toxic keratitis that's out there. So this one here would be easily treated with what? Stop the drops, hit them with maybe some non-preserved artificial tears every hour, and just check them back in a day or two, and you'll probably start to see that resolve. Now, you have to use Rule-FDA from time to time whenever you can't get Zirgan or the insurances don't cover it. But Zirgan, 0.5%, has a much higher affinity for the virus. So, when you hear in pharmacology, you hear, what's the mechanism of action? Is it safe? What's the efficacy? So between the two medications, I can tell you that Zirgan is much more efficacious than using trifluridine. So anytime that I have a dendrite on the cornea, I'm going for Zirgan, but then you run out, sometimes you run into those insurance issues, or they just can't get it, and the only thing that's in stock is Rule-FDA. And Rule-FDA still works, it just doesn't have the high effectiveness or the high affinity that the Zirgan does. And you can see that because you're using 9 drops a day versus 1 drop 5 times a day until the cornea heals or starts to get reversals, what I like to say. And then you start using 1 drop 3 times a day once that happens for the next 7 days, and you'll cleaned out that virus. But you warned that patient, that this is a 25% chance coming back. 5 months later, here's the patient back. They have these nice dendrites. So what's going to be your treatment? Zirgan, artificial tears, steroid, probably a steroid once you get some type of reversal. And then what I usually do is just add the steroid once or twice a day, check them back always the next day when you add that steroid, just to make sure that you're not causing any more dendrites to pop out, any type of corneal melt, any type of complication. Now, is it time? Remember, this is 5 months later after you healed the original ulcers. Is that 37-year-old, woman that came in, orals at this time, hopefully, possibly, you're going to educate them that since this is the second time in the last year that this has happened, that this is a 43% chance of coming again. This is all coming from the herpetic eye disease studies 1 and 2. That's where these statistics are coming from. You're going to say to the patient, hey, there's a 43% chance, with that being said, I want you to know that I can put you on a maintenance dose of orals to prevent this from coming back. And you know what most of the patients say most of the time? Hey, doc, that's good information. Thank you for telling me. Make sure you document it in your record, right? Because in case anything happens, hey, that doc never told me that you can go on acyclovir, and they ended up with some cornea vision loss after the 3rd episode. Make sure you document it. Patient declined. That's all you really have to do for that situation. So you fix that one, and you can see where I'm going with this. The patient has, come back the next 4 months later, and they have that classic dendrite on that central cornea. 3rd episode, Zirgan, artificial tears. When are you going to add the steroid? When you start seeing this reverse, check them the next day. And that's whenever the patient may go on, or most likely will go on, especially if they're getting annoyed by that maintenance dose that came out of the herpetic eye disease study. So what I like to do for these, and the academic side of this, is since herpes simplex is so wimpy, they'll say, okay, it's 500 milligrams of Valtrex and 1,000 for Valtrex if it's zoster. So simplex is 500, zoster is 1,000. These medications are so safe. Really cool how they work. As you know, when you take a medication, it goes into every cell of the body. When you take an oral antiviral, what happens is it goes into every cell of the body, but it only becomes activated in the cells that have the virus. So the virus produces a certain enzyme. It's like one of the byproducts. So what happens is the virus produces an enzyme. So these are all, in a sense, prodrugs, and it activates the medication to then go kill the virus. If it gets into a cell that doesn't have the virus, it never becomes activated, and there's metabolism in a cell, and these all have half-lives. The medication just goes away. So it's a very, very safe medication. So what I like to do when these patients come in and I say, hey, look, this is the 4th time, this is your 3rd time that you've had this in the last year. 4 months ago, that you were here with one. Now you're here 4 months later. I'm going to put you on Valtrex, 1,000 milligrams, as I treat this other ulcer over here, maybe with Zirgan. If it's starting to swell, get cloudy, maybe using the amniotic membrane, yes or no. Just remember that that's a tool that's here for treating these. And I'm going to do that for about a week. And all I'm trying to do is reduce the viral load in their body. Once I resolve this or get them out about 10 days, then I drop them down to the standard dose, which the herpetic eye disease study said, 400 milligrams twice a day, or you can go to 500 milligrams once a day for that. So I'm going to ask you yourself, ask everyone out there, the cornea dynamics. Is the flow through the cornea front to back or back to front? So let me just say it this way. If you had an abrasion on the eye, what's the fluid dynamics? Is it again, front to back or back to front? And I see people commenting in the chat box. And then I have a question here. Do you always put a steroid on, or just if they have stromal or endothelial involvement? I'm going to say probably 90% of the time they end up with some type of steroid that's on there. I see them back. I see them on day one. They have a nice big dendrite. I feel pretty confident to say to the patient, hey, look, I've treated enough of these. I'm going to see you back in 2-3 days. Just if I'm using anti-infectives, and if I see reversal, and if I see that swelling, if I see that stromal edema, then I'm going to put them on a steroid. So I'm seeing a bunch of mix here. I see back to front, front to back, front to back, back to front. And where I'm going with this is with these pictures here. And I'm just going to pretend that, I got this guy right here. This is a guy that tried doing a LASIK flap on himself. This is the left cornea here. He was actually trying to take, in Western Central Pennsylvania here, we do a lot of our own car work. So he had the tire off. He's trying to get this rusty brake, and boom, the screwdriver cut right across his eye. That's kind of in a sense, a kind of a poor LASIK flap. He had another laceration up in his upper orbit. Luckily, it bounced off. It didn't go that deep. It went about a third of the way through. I have a nice cool OCT on this. But if you look right here, he's got a hyphema. And here's a dendrite of a patient, but you can see I have a ton of sodium fluorescein in. And I love these pictures because this is what happens when you have an epithelial break. I'm going to pretend that, Vanessa called me, and I'm like, oh, Vanessa rarely calls me. I need to go take this patient. I'll be back in a second. And as I come back, if you look, the sodium fluorescein has gone into both of these wounds. This is an infection. This is a traumatic wound. But because there's so many endothelial cells, it's pulling in the sodium fluorescein. So the answer that I was going for was front to back. Now, that's not a great question maybe, because I think I did tell you that there needed to be an epithelial break. If there's no epithelial break, it's going back to show you how important that epithelium is. The epithelium is intact. Then the sodium fluorescein, I could put sodium fluorescein in an eye. Joe could call me. I can come back 10 minutes later. It has not been pulled into the stroma. Okay. Trust me, guys, there's a reason why I'm telling you this. And I think it's going to be seen on this next slide. And the reason is that if you think about what happens when, and this goes back kind of the steroid question, is that when you have a bunch of dead bug that has come through that neuron, right? So let's see if I have like this right here. So we have this classic dendrite, or that one that I showed you before. And that virus has made its way through, its neuronal that we learned way back at the beginning. And that virus makes its way into the cornea. And you use things like Valtrex and Zirgan and you kill it. What do you have? Dead protein, right? And I always use the analogy, and it's, it's like roadkill on the side of the road. I'm driving to work and then I see a dead animal, and every day I drive by it, it's less and less and less because there's other animals out there that are benefiting from that and kind of cleaning up that roadkill. But we know that it starts to decay. So when you have dead bug and you have dead virus, dead protein on the eye that's foreign, and that wound has been opened up by the dendrite, what happens is all those endothelial cells, just like the fluorescein here, sucks it into the stroma, and you get a stromal reaction. So what I like to point out is that the infectious part is the epithelialitis or the epithelial disease, but the stroma is more of an inflammatory reaction. And it's just by dynamic of the fluid of the eye. When you have an open wound, the dead bug gets pulled into the stroma, inflammatory reaction. If there's enough bug that goes through that 500 micron cornea through the endothelial cells and into the anterior chamber, you can get an iritis. Now that we know that the epithelial is the infectious side and the stroma is the inflammatory side, the herpetic eye disease study, kind of really enforced what we kind of already knew, where we say crime must fit the punishment. There is a benefit from steroids and in stromal keratitis. Stromal keratitis is what? Infectious or inflammatory? Well, it's inflammatory. The dead bug has been pulled in and you have an immune reaction. So that's why it benefits from a steroid. There's no benefit from oral acyclovir in stromal keratitis. Again, the crime must fit the punishment. It's not an infectious disease when it's in the stroma. It's inflammatory. Dead protein has been pulled in there. So that's why the herpetic eye disease study showed that there is no benefit. Maybe the oral acyclovir, when it was infectious, created the stromal keratitis, but you had to kill the bug. And then I think this one all makes sense, right? There is a benefit from steroids if there's an iritis present. But the herpetic eye disease study set us up, and it said that there's no benefit from acyclovir to stop the progression to stromal or iridocyclitis. And that's another reason why I go through that long drawn out talk, is that when you use the acyclovir, you're actually killing the bug. So you're not really stopping the progression. You're stopping the progression of the infectious ulcer, but then the ulcer itself has opened up that wound and it pulls it in. So there's no benefit from stopping the progression. And it goes back to the question, do I always? Well, most likely always, or sometimes always, or whatever way you want to answer. It's not always, but most likely based on cornea dynamics and fluid flow, that I am using some type of steroid to minimize that stromal or maybe anterior chamber reaction. But one of the big numbers that came out was to use a maintenance dose of 400 milligrams twice a day, and that will decrease the occurrence by 41% a year. So that's why when this is the leading cause of cornea vision loss that's out there, it's important to know that after kind of that second episode within a year, start bringing it up, because there's, as we would say, evidence-based medicine out there. And, why didn't you bring it up? So I bring it up, but I can tell you that majority of the time, people don't want to go on a chronic medication unless they're a cold sore sufferer. If they're getting a lot of cold sores on their lips or in their nose, and now it's coming out on their eye. And that's a question I ask a lot. Do you get a lot of cold sores? You know what? It's starting to come out on your eye right now. Why don't we maybe decrease this viral load for a few months and, keep you on some type of maintenance, let that immune system recover a little bit, and see if we can get you off of this later on, maybe 6 to 12 months, to see if we can stop some of these recurrent episodes, because there's just something out there that the patient is lacking that's causing these to become recurrent. So recurrent herpes simplex keratitis, you got topical treatments, topical antivirals, you got oral antivirals. Always remember to check for allergies. This patient is allergic to penicillin and Keflex. And remember, she's 37 years old. She's getting these recurrent infections of her cornea, and she's 2 months pregnant. Can we use these medications? We're going to find out. So medical history, before we prescribe any medications, we always take a thorough medical history, chief complaint, the history of the present illness. Within the review of systems, we always want to look for kidney disease, liver disease, dialysis, things like that. And in this case, for sure, kidney disease. If there's one thing that I want to jump up and down and wake everyone up that's out there, is that these medications are cleared through the kidneys. So you want to make sure that in the short episodes, not a big deal unless it's end stage. But if you're going to go chronic, work with your primary care doc out there and just say, hey, look, I'm putting this patient on an oral Valtrex or acyclovir. And would you like to get their kidney function test now? Because they're probably going to be on it for 6 to 12 months. And then let the primary care, just the doctor say, oh, go ahead and start it and I'll get it within the next week or so. And then we'll measure them, 4, 6, 5 months down the road to make sure everything's okay. Past family social history. We have current medications, allergies versus, adverse reaction, and then, checking for pregnancy out there. So just a real quick reminder of a review, the FDA pregnancy categories. The old categories are A, B, C, D, and X. And X just sounds bad. It creates fetal abnormalities. Basically, A and B are safe if a patient is pregnant, and then C and D, you have to start taking in the risk versus benefits. And then just as a reminder, December 4th of 2014, and the older medications had a chance to be grandfathered in, but the new medications that are out, things like, Xiidra and Upneeq, they use this new nomenclature looking for pregnancy, lactation, and any other issues to the reproductive system. And that's found when you open up a package insert now under 8.1. So if you have something in the office, there's a sample, or you can just Google the package insert for any of these medications, just automatically just go to section 8. 8.1 will talk about pregnancy if there's any risk summary that's out there. 8.2 will talk about the lactation, and then 3 will talk about the reproductive system. 8.3 talks about any problems with the female or male reproductive system. And you can see here that this is Valtrex, and they did convert over. You can see that it says 8.1, 8.3. So they do have something to report under section 8.1. They kind of kept the old nomenclature. You don't see this on the new stuff. You can see category B. Now remember, this 37-year-old woman was pregnant. So it is safe to give pregnant, and that goes across all the orals, Famvir, acyclovir, and Valtrex, able to give oral medication because they're category B. And you can see here that there's nothing on 8.2, but you can see they jumped to nursing mothers on 8.3. And this is just Xiidra. This is just kind of showing you Xiidra is showing you here. They've adopted to 8.1, 8.2, but there's no 8.3. And you can see here that they really didn't put a category in here. So you'll see on the older medications, the hybrid categories / then there's a risk summary that's out there. So that's where you look whenever the patients ask. Now, again, I'm going to jump up and down. Renal impairment. You want to identify patients that are on hemodialysis. Not such a big deal. Might not want to send them and start them on Valtrex the day that they're having, their dialysis, because you flush all the medication out. But you could talk to the doc and they'll probably say, yeah, go ahead and use it. But if they have kidney failure, then they're going to adjust it based on the creatinine clearance. So it's not to say that you can't use these medications. Just identify it, work with the internist, work with the primary care doctor, be a teammate here in a sense. They'll like it. Oh, thanks for seeing us. I know it could create lots of problems, vision loss. I'll help you with the renal adjustment that's out there. We kind of talked about this a little bit earlier. The oral antivirals back in the day, the first generation got a bad rap. They were mutagenic. They created cancer. The third generation don't do that. They've totally changed the molecule. They're not cancer producing, and they're kind of neat the way they work. As I mentioned earlier, they go into the cell that has the virus. Well, it goes into all the cells, but the cells that have the virus produces an enzyme, causes that medication to activate, and it kills the virus, kind of like a little Trojan horse. Sometimes you'll see corneal specialists on someone that's had a herpes keratitis use it prophylactically for penetrating corneal transplant, LASIK, or even PTK that are out there. So my question is for those that are on the webinar here tonight, and I'm already there, Joe, so I'll launch it, is what is your go-to oral antiviral when you're treating a patient? What's your go-to? Is it acyclovir, famvir, valacyclovir, which is Valtrex? I don't have one. That's why I'm here. Or I'll place something else into the chat box. All right, let's see here.
Greg, while we're waiting for people to weigh in, I'm going to go back to the dendritic keratitis and throw out something and see if you agree, disagree, if there's any merit for my clinical referral.
Yeah.
But one thing that we had before we had antivirals that were effective was corneal debridement. And we were able to cure 75% of epithelial disease and herpes by debriding the cornea, physically removing. Now, I myself will still do that. Now, when I say debridement, I don't mean taking a John Deere power spud or anything like that. I'm talking about taking a contact applicator. I will roll it over the lesion several times. Then I'll gently wipe the lesion. I'm not looking to create a corneal abrasion. I'm looking to remove some superficial virus. And then I go into the therapies. And I think that by physically removing some virus, I think it makes it go a little bit easier for the patient. What are your thoughts on that?
Yeah, I mean, I've heard that done. I've heard corneal specialists, non-corneal specialists talk about it. I believe all you're doing is reducing the viral load and giving the body less virus to have to deal with. It's superficial. You're taking some away, and I think that helps. I have no experience with that, but I've certainly heard people like yourself that have done it, and other people talk about it. I'm not sure if there's anything out there in PubMed where they've actually done a study on it, but I certainly don't think it can hurt, especially in a huge dendrite or maybe even in a dendrite that's centrally located. No, I think it has lots of merit.
Well, actually, there is something out there, and it's years old, and they actually compared debridement to the use of debridement with trifluridine, Veroptic, and they said if you're using Veroptic, it doesn't help, but that's very old. And when I fall back and understand that 75% of these used to be cured with debridement, I will roll and then I'll rub and try to get some off it. But there is some study that said, no, it really didn't help with Veroptic, but we're not really using Veroptic that much any longer.
Right. And that could be it because of the toxicity that the Veroptic has. It kills the virus, but it also creates a big corneal issue. So that might have been the reason why, but I certainly don't think there's a reason not to do it. So no, I like it. Thanks for bringing that up. So you can see here the go-to for the audience tonight, acyclovir, famvir, 8%, the winner is Valtrex, and 19%, they don't have one, and that's why they're here. So thank you for being here tonight. So let's go through these real quick. You have, Zovirax or acyclovir. It's good for Simplex and Zoster. It's available 200, 400, and 800. Here's the issue with all the antivirals. They don't penetrate the gut wall real well. They're probably water soluble. They get up at the gut lining is fat, it needs to be fat soluble. So it's very hard for them to get through the intestinal wall to be absorbed. And that's why, you see a lot of 800 milligrams, and then you have to get it through the gut wall, into the brain, out of the brain. So, there's a lot of, the blood-brain barriers that are out there. So that's why 800 milligrams 5 times a day or 4 grams a day is used, again, for that, because of that poor GI absorption. When you go to maintenance, as you saw from the herpetic eye disease study, 400 milligrams twice a day. Usually when I do that is after, if I'm going to use acyclovir, it'll be after a course of 800 milligrams 5 times a day for an X amount of period, and then dropping them down to 4 times. You're going to see this on, again, every single slide. Caution with the kidneys, renal impairment, they're excreted through the kidneys. And then if you go maintenance dose, make sure that, you work with the PCP to make sure that they monitor those kidney functions. And it's a category B. Now, I get this a lot of times, off-label discussion. And if you try and look up in the PDR at least, or talk to the Valtrex or famvir rep about, I use this for, ocular disease, they're going to be like, scatter, because you're off label, right? And we all heard of those companies out there that got big fines by using things off label, then that starts putting question marks in our mind. Can we use this off label? And the answer is yes. If 3 out of 4 corneal specialists are doing it, or 9 out of 10, then it becomes more or less the standard of care. So when it comes to off label, just make sure, in a sense, it's the standard of care, because Valtrex and Famvir are only approved for genital herpes. You're not going to find it in the PDR. But if you go to PubMed or any other research, Google, if you want to use that, and you look up articles out there or how people are using it, you could see that you could use this out there. So off-label doesn't mean that you can't use it. And I say that all the time, because if you think about all the 4th generation fluoroquinolones, and I think that goes for all of them that's out there, they're all approved for conjunctivitis, but they're not approved for central corneal ulcers. And that's the standard of care, right? Someone comes in with an infectious keratitis, bacterial. The standard of care is a 4th generation fluoroquinolone, but they're all approved for what? Bacterial conjunctivitis. So don't be afraid to use Famvir or Valtrex to treat the ocular infections. Now, Famvir is probably the one that's used the least that's out there. If you're going to use it, you're going to use the 500 milligrams 3 times a day that's out there. If it's a recurrent Simplex, you're going to use 250 twice a day as your maintenance dose. Again, what's the recurrent theme? Impaired kidney function, long-term. Make sure you get the kidneys checked, category B. Now, Famvir is no longer available in the United States as a brand name, but you can get it as a generic in the United States. Valtrex is a prodrug of acyclovir. That's why you see acyclovir in the name. It's just valacyclovir. Short name, or the branded name is Valtrex. It's available 500 and 1,000, and pretty much it's good for type 1, type 2, and the Zoster virus. And I typically use, remember, 4 grams was acyclovir, 800 milligrams 5 times a day. And what we're doing with the Valtrex, it's a big pill, 1,000 milligrams 3 times a day, so 3 grams. So 4 grams down 1 to 3 grams of the Valtrex. Recurrent theme, I told you to see it the whole time, renal and function in category B. So all of them are safe to give to someone that's pregnant. So check this out. Here's that 37-year-old, right? We got into that long discussion of all those different pearls that were out there. This is that 37-year-old female that came in the 3rd time. Zirgan, caution, and Veroptic. Remember, it's category C, those medications. So it's topical. It's central. I would probably use it for a few days to get reversal. But you could use your oral medication, Valtrex, safe category B. You could do 1,000 milligrams for a week and then drop her down to 500 milligrams once a day, since it's been recurrent. You're going to use a steroid to get, once you see some reversal, and artificial tears, pretty much in all these cases. Then I'm talking here, consider L-lysine in some of these patients that are out there. It's kind of, a nice amino acid that we'll talk about here towards the end. So beside the dosing frequencies that are out there with these medications, are there any difference for these oral antivirals? So here is from the herpetic eye disease study. This is from the New England Journal of Medicine. This is all the way back from 1998. Is there any, what's the main reason for early discontinuation? The people that were in the study, there were people that stopped the study. And the number one reason is some people had some rash, but the number one reason was GI upset. That was the number one reason why people dropped out. And if you even go back to some of these slides that I was showing you here, you could see GI upset. And it's really with Famvir and acyclovir the most. And the reason is when you look at the medications and you see what's in here as the active ingredients and inactive ingredients, I'm going to circle this one right here, and I think I have it highlighted. Check this out. Zovirax, which is acyclovir, has lactose in it. You can see Famvir has lactose in it, and Valtrex has no lactose. And we all know that there's a lot of patients that are out there that are lactose intolerant. So when you ask me, now that it's generic and it's been generic for quite a few years, what's my go-to antiviral oral when treating these medications? It's pretty much what the audience at 44% said is Valtrex. And then one of the main reasons is that it's 1,000 milligrams 3 times a day, as opposed to 800 milligrams 5 times a day. And the other probably more tipping of this scale is that it's lactose free. And we all know that there's a lot of patients out there that are lactose intolerant. And the good news is Valtrex and all the generics did follow the recipe. Don't always have to when it comes to the inactive ingredients, but at least in all the generics, they're lactose free that are out there. In Europe, there is a Famvir that is lactose free that's out there, just to kind of be fair and balanced. So when it comes to the elderly, is there any difference in using these medications? And again, this came from the herpetic eye disease studies and the different studies that are out there. And I have a classic patient. I had a patient that was in the Pittsburgh area. She was like 90 years old, and she needed to move back with the son and daughter, or the son and daughter and son-in-law, and because she was getting older and needed a little bit more help around the house. And she had, I think, bilateral cornea transplants, and the one eye didn't see real well, and the other eye was still seeing pretty decent. But they kept her on because that's the reason why she had all these corneal transplants. Remember, it's the leading cause of cornea vision loss. She had bilateral cornea transplants, maybe 2 or 3 on one eye and 1 or 2 on the other, and they were using a maintenance dose, but it was 1,000 milligrams 3 times a day. So and that was Valtrex. And as I was talking to the daughter and the son-in-law, is there anything like strange going on? Because she was probably 100 pounds soaking wet. And so they started talking does she see things? They're like, oh yeah, it was very much like Charles Bonnet type of hallucinations. Kind of like a release solution. Yeah, every so often she'll see like the old Studebaker or whatever, so on and so forth. And I'm like, okay, there is a little side effect of these medications when they're given that high. So I know that the surgeon wanted to try and prevent, so we were able to slowly get her off. I did, 1,000 milligrams twice a day for a certain period of time, made sure nothing happened, and finally got her down to 1,000 milligrams once a day as a maintenance. And those Charles Bonnet / hallucination agitations went away. So when you give these medications at high levels in an elderly population, just be aware that they can carry that kind of central nervous system type of adverse effect that's out there. But of them all, Famvir is the least that causes it. So Famvir is the least out of all of them. I guess if this patient still had those hallucinations, I might have considered Famvir, because the studies have shown that Famvir is the least, but luckily they either went away enough that they weren't as annoying to her or the family that it was just, we kept her on the Valtrex. So just be aware of that, just like the lactose. Is there any difference between topical and orals when it comes to treating this? So we have Ganciclovir as a gel, as Zirgan. We have the orals that we just talked about, Acyclovir, Valcyclovir, and Famvir. And there's multiple studies out there, and these things are not new. And there's even newer studies that are out there, but you can see here, 1986, 60 patients with herpes simplex, small number of stromal keratitis. Was there any statistically significance between using topicals and using orals? And it says, here in 2010, oral acyclovir alone seems to be as effective as topical viral therapy when it comes to simplex keratitis. Now, back in that day, it was just, trifluridine. Trifluridine is, pretty toxic keratitis to the, pretty toxic to the cornea, creates a toxic keratitis. Zirgan is much more gentler. So, I put this out for a couple of reasons. Is the way back at the beginning, how many times have you ever had a patient that, that you had a dendrite and the pharmacist said, hey, look, I can't get this for next 24 to 48 hours. Check all the pharmacies around, can't find it. You're going everywhere looking for these medications. Don't forget that you can go oral. And if it's out in the periphery, you might just resolve it alone by going with an oral, and then maybe getting a steroid on board once you get some of that reversal that's out there. But I'm still a big proponent of putting the patient on a topical, especially if it's central, knowing that it's the leading cause of corneal vision loss. But you can see here that there's a study or a few studies that say that you can go with just orals. All right, I got a direct message here, so Joe's not going to see it. Just curious about the duration of orals. Do you write 7 days with a refill, or do you write a longer duration out of the gate? If it's the first episode of a herpes simplex, I probably just do 1,000 milligrams 3 times a day for a week, especially if I'm going topical. If it's a couple, if it's their second episode and I'm starting to talk to them about if they're going to not want to go on a maintenance dose, then I might write, a 2 or 3 week supply. And then once I get that reversal, get them down to maybe 2 times a day for a week, and then once a day until the prescription runs out, especially if they're in, that second episode within a year, just trying to help reduce that viral load to a certain point that maybe the immune system then can keep it at bay. That's out there. So most of the time it's, if I'm going to do Valtrex, just on a herpes simplex first episode, or an episode that hasn't been around for maybe 2 or 3 years. Hey, doc, remember you treated this back in 2015? I'd probably just go for 7 days on that, on most of those. Herpes zoster, a little bit different. I'd probably do 10 or 14 day. It's always going to be Valtrex. I shouldn't say always it's going to be, but 99.9% of the time, if I'm going to treat a zoster, I'm going to go with Valtrex, and I would probably do a 2 week, again, because they're so safe that's out there. I would probably do a 2 week dose on zoster. Again, just trying to help that viral load to become reduced, to allow that immune system to then kick in so that they don't get another outbreak of the zoster. I bring this up as kind of maybe a functional medicine type of thing. There's lysine and L-lysine. And what are those? Those are 2 essential amino acids. And it's essential for human health. But your body does not produce this like through an enzymatic. You have to get it through food supplements, kind of like carotenoids that are out there, right? So the carotenoids that are in our body, those antioxidants, some antioxidants can be produced enzymatically, but carotenoids, lutein, zeaxanthin cannot. And that's why you have to take them through fruits, vegetables, kale, spinach. Lysine is another one of those that your body cannot make. So you have to take it through food supplements. So these amino acids, there's studies out there. If you just Google L-lysine, I have patients that don't want to be on a chronic, acyclovir or Valtrex, or I'll start them on Valtrex and then start them L-lysine and use them both, but then get them off the Valtrex and see if the L-lysine itself can help it out. And I've had a few success stories out there. So there's some studies that found by taking lysine on a regular basis, it can help prevent these herpes simplex virus from replicating and preventing these outbreaks. And from all the reading that I've done from all the different, when I do the PubMed searches, when you have someone that's in an active infection, obviously you're still going to use your orals, you're still going to use your topicals, but if they have an active infection, or maybe they're just allergic to everything, I can't think of a time where you only would use this, but there might be a chance you would do, 2,000 to 3,000 milligrams a day. And then if you're trying to do preventative, you want to put them on about 1,000 milligrams of L-lysine. And that's just found in the sense, the vitamin IO. And I'm sure that there's different variations and different potencies and different, which ones are better that are out there. And then I don't know that answer for you. So with that being said, back to another Cranium Keeper that's out there. You have the percentages. I don't remember too many percentages numbers, but this is one that I keep, and I see a lot of herpes. Some of the ophthalmologists in the area send them over. They're like, oh, Greg just feels comfortable with it. Let him, in a sense, deal with it or treat the patient. So I've kind of learned these numbers because 25%, that's after that first episode. And that patient probably was the last drop that they used was a steroid. And I want to make sure that they know that there's a 25% chance that this can come back in the next year. And even though this drop made your eye feel good, if you do use it, please call me because, maybe they'll use it and it'll bring out the herpes simplex, make an easier diagnosis. But, please don't start any medications, until I see this, because we want to hit it with the anti-infective first before we hit it with the anti-inflammatory. So again, after the first episode, 25%. If they come back within that 12-month period, within that next, so they have a 25% chance. If it does come back within that 12-month period, there's a 43% chance that it can come back. And then the herpetic eye disease study, I think the number's low because I've had a really much high success by using Valtrex 500 milligrams once a day or the acyclovir 400 milligrams twice a day, of really not seeing an episode come back in a high amount of patients within a year. And I would say as high as 90% that's out there. But this is the herpetic eye disease number, so we just use it. All right, we have a question here. Which topical steroid do you prefer for this? Probably one of the lotopredanols that are out there, just for the fact that sometimes they end up on it chronically, meaning they could be on it for 2 or 3 months, especially if they have an iritis, especially if it gets into the stroma. And then you have the cataract and IOP issue. The ester form of the lotopredonol molecule, it's very safe. It doesn't cause that pressure spike and minimizes the cataract formation. But in the anterior surface, it's very potent. Now, if I was trying to treat something maybe in the back of the eye, maybe I wouldn't use it, but something topical like this, a lotopredonol. So thanks, Karen, for that question. All right. So vaccines, really, there's no question. Sometimes I do this talk with Dr. Tracy Offerdahl, and she handles this part. But when it comes down to Zovirax versus Shingrix, there's really no usage. And I could ask her if it's even being used anymore. It used to come in that patients be like, oh, should I get Zovirax or should I get Shingrix? And maybe it's when before Shingrix was out, and we know now the safety profile of it's very good. But Shingrix has 90% efficacy as opposed to the 50% with the Zovirax. So, if you're going to get it yourself, I'm 51 now, starting to think about, what things I have to do. And Shingrix, might, is going to be the shot that I get eventually because of the 90% effectiveness that's out there. It's a recombinant virus. It's got an adjuvant that's in it that really makes it solid up to about 8 years that's out there. And you can see that Zovirax was about 4 or 5. So when it comes to prevention through vaccines, again, Zovirax was by Merck. You got Shingrix originally by the GSK, intramuscular injections. And you can just see here that shingles reduced by 97%, 90%, pooled data over here, 89%. And here you could see, as low as 38 up as high as 70%. So if anyone ever comes in, or if you're doing it for your friends, your family, or for patient care, and they bring this question up, Shingrix is definitely the way to go with your vaccine. So we got some to kind of wrap out this next few minutes here. Serious complications of herpetic disease. There's neurotrophic states that are out there. You have acute retinal necrosis. You have post-herpetic neuralgia. Now those are moving in, and this is part of that, herpes A to Z. This is kind of, I guess, the Z part where, you don't really see it that often, but, it's that saying, it's not rare if it's in your chair. So post-herpetic neuralgia, how to treat it or how to maybe possibly avoid it. So post-herpetic neuralgia, this really decreases the patient's quality of life. It creates interference of activities. And it's approximately about 1 million cases of herpes zoster a year happen in the United States. And then of those million cases of zoster, 1 in every 3 people develop herpes zoster in their lifetime. So the key is there's a fair amount of zoster. And post-herpetic neuralgia is a frequent complication of about 5 to 15% of the cases, and some of it causing moderate to severe neuropathic pain. And that's something important that I need to mention, is that it's neuropathic pain. That's not your inflammatory pain. It's that, we don't really truly understand the mechanism of it, but it really doesn't respond to the opioid treatments. And so post-herpetic neuralgia is a pain that can persist for months, even after the rash has gone away. Those nerves become super sensitized. They're almost, super sensitized to just, I had a patient come in and had it on her arm, and she literally had a silk blouse on, and she had the sleeve cut off. And she's like, look, even if the silk blouse touches this, I had shingles on my arm. It just inflames it, or it just makes it uncomfortable for the patient. But here's the key. Neuropathic pain does not respond to that non-opioid analgesic. That would be, your aspirins or your Tylenols. And it doesn't respond well to even the opioid drugs that are out there. So you can't really treat it with the non-opioids and the opioids that are out there. Again, it's an unclear mechanism, but it does seem to respond to some antidepressants, some anticonvulsant drugs. So the approach is, when you're treating post-herpetic neuralgia, is preventing the herpes zoster through vaccines, right? That's really probably the best way to do it. And that's the reason why the vaccines need to be out or need to be used in these patients. And that's why we covered it a little bit earlier. Administering specific medications to help treat the pain. These are the first lines that are out there. That's why you'll see when patients come in and they're having neuropathic pain, you'll see them using things like Neurontin and the Lyrica that's out there. So Lyrica and Neurontin, these are anticonvulsant, but they're used, they have a secondary, they found like, hey, they're using these for as an anticonvulsant, but hey, my neuropathic pain went away. And that's the way a lot of these things get discovered. So that's probably the number one medication out there, Neurontin and Lyrica for neuropathic pain, because you have to be careful when you start using tricyclic antidepressants with some of the cross reaction of other medicines out there. And, amitriptyline, you have to be careful with using that, these MOI inhibitors. Now, when you're treating, for like a zoster type of thing, now maybe not around the eye, but this lady that I was telling you about, had this silk, topical lidocaine patches work well for some of these patients that are out there. So the question that came up one time that in my office is, the patient came in, she had all this pain, but she was still like 2 years out from when she had this episode. So I'm like, I wonder if Lyrica or Neurontin would help this patient. So I was able to hop on the PubMed, and, there was a study that was done. You can see it was referenced down here. I have it referenced. And it was in 2016, and the question was from the study, does the duration of neuropathic pain impact the effectiveness of Lyrica? And they found out patients with chronic pain conditions such as neuropathic pain frequently experience delays, right? Because it's hard to know like what it's truly from, or hey, it's that neuropathic pain from diagnosis and treatment. And they found that it, irrespective of the length of time, that the Lyrica or Neurontin would still work. So that's pretty good. That's out there for these patients. So we'll see that a lot. I have patients just coming in talking about on their arm or on their leg, let alone their, around their eye. And this is a nice little tidbit of information like, hey, you might want to discuss this because, there was a study. I say, look, I lecture on this. It's in one of my lectures that, you might want to reach out and talk to your primary care doc about Neurontin or Lyrica, even though it's been a year, 2 years, or 3 years down the road, you might get some benefit from it. All right, let's see. How long does the Shingrix vaccine last? And that's why I like doing these with Dr. Offerdahl. I believe the Shingrix can last up to, what was in my slide? I believe 7 or 8 years. And then, you might need to get a booster shot. And then what is the rationale of still getting the Shingrix vaccine after the shingles episode? And that I do know is that, the body's immune system is weak. Your body has the Zoster virus in your body as a neuronal virus, and your immune system just, in a sense, can't keep it at bay. So just like with the coronavirus, you get the first injection, it goes through the immune system, it creates those plasma cells to kind of make those antibodies that are ready to attack whenever you have that next outbreak. So it's to create the memory. That's the reason why, so if you had an outbreak, your body has made it, but it maybe not has made enough. So you have the Shingrix out there to really make that memory of the B cell, because it's a different type. It's that recombinant virus. And then they put that adjuvant in there. A good way to explain like an adjuvant would be augmentin, which is amoxicillin and potassium clavuronate. The potassium clavuronate has no anti-infective ability. It's the amoxicillin. But what happens is the potassium clavuronate absorbs the beta lactamase so that it doesn't make the amoxicillin inactive. So that's kind of how like two medications, put together, one being adjuvant. Tracy always makes fun of me because I say it as a French way, but the adjuvant side of that, they work together. So that's kind of how Shingrix works, and that's how you get that higher percentage that's out there. So for post-herpetic neuralgia, you could see that they're trying different things to help these patients that are non-medical or non-medication or non-pharmaceutical. There's pulsed radio frequency, a new method for the treatment of neuropathic pain, that they're just trying to find ways to help these patients that are out there. Early application of low laser therapy is out there. So when patients come in, there's, my area, there is a neuropathic pain doc. We can get these patients because it's a whole different type of pain that is, it's not narcotics, it's not analgesics. And so there are different ways. There's the anticonvulsants, the tricyclic antidepressants, and then there are, low laser therapies and this, pulsed radio frequency that's out there. So the main risk, advancing age. That's why you'll see a lot of the times you'll see the primary care docs, they'll just treat them with, 1,000 milligrams of Valtrex. They'll put them on steroids. They think that helps decrease the risk of it coming of the post-herpetic neuralgia. The severity, that's why it's best to catch it early. A painful prodrome prior to the cutaneous eruption. So, this patients come in and feel like they're bugs crawling on them. If it's painful, that's not such a good sign that they're going to, or it's a good sign that they are going to have post-herpetic neuralgia, but not a good sign. You don't really want to see that. It's probably a bad outcome that they're going to have post-herpetic neuralgia. People that are chronic illness, those are things that can create it. So the treatments, topical capsaicin analgesics, lidocaine patches, and you can see the list there. It goes on. Here's one I didn't mention, acupuncture. I've heard of patients getting acupuncture. Oral steroids and antivirals do not prevent the incidence of post-herpetic neuralgia. And again, that's why, you'll see some of the primary care docs put it on there, but studies have shown that it doesn't really do much, at least for the post-herpetic, but it does come back on the scarring and the outbreak that the patient is having that's out there. Neurotrophic corneal ulcers for the next few minutes here. Then we'll talk about some retinal complications, and then we'll wrap up this evening's webinar. So neurotrophic corneal ulcers, it's difficult to manage. The reason being the cornea is not as innervated as it should be. And when that happens, it's a big negative feedback loop. You have decreased tear production. Medications you certainly want to avoid in a neurotrophic keratitis is corneal steroids, as it may increase collagenase, and you don't really want collagen breaking down, which will then promote a stromal melting. You don't want to do topical NSAIDs. They're already corneal desensitized enough. You don't really want to give them, in a sense, a numbing agent, which is what a topical NSAID would do. And it has shown that there's no benefit in wound healing, and it can cause, that decrease in corneal sensitivity, causing it to worsen over time. So some traditional treatments that are out there. This is before maybe we talked about earlier today, amniotic membranes, and then Oxervate that came along. But just in case, you're having issues and, patient's insurance won't cover an amniotic membrane, it's always a few weeks to get the Oxervate. Don't forget, preservative-free tears and gels and ointments, and discontinuing any topical medications that can cause corneal sensitivity loss, which would be, timolol. And you can see that they're the NSAIDs that are out there. Acetylcorolac is being one of them. Those that contain preservatives, so we want to go as preservatives free. You could do punctal occlusion, doxycycline. If you go way back at the beginning when I said, what are all the orals that we can use when you're talking about, herpes eye disease? We always fall back into the antivirals, but there's L-lysines and your anticonvulsants for the neuropathic pain. And now we're going to talk about doxycycline, and it's good for its anti-inflammatory properties for the same reason, that we use it in a sense for maybe meibomian gland dysfunction. Because of its anti-inflammatory properties, it can inhibit the collagenase that's produced in these corneas. And it can inhibit the MMP9, which is another inflammatory marker. So doxycycline would be used more in the neurotrophic cornea side to help out. Vital Tears has been great. They've come back out, no financial interest. The autologous blood serum, been great to use at the office. It's great to have it back and solving a lot of issues that are out there. So doing someone as they're waiting for their Oxervate to come in and they can't get an amniotic membrane, some Vital Tears and some doxycycline and lots of preserved tears. Some alternative treatments, we talked about amniotic membranes, but scleral contact lenses. You can bathe that cornea in a solution and help keep it wet and help promote some healing. And then you can see in 2018, Oxervate came out, Synnergym, and that BKBJ means nothing. I get a lot of questions on that. That is just as the biosimilars come out and they go into registries, because a biologic is an exact replica just made by another company, because it goes into some living cell. I'm not sure if it says on here which one it is. Sometimes it's it's E. coli or a hamster ovary, and they put the sequence in and then it comes out and then they twist it all up. And that's what this is here that Dompe has used. And they do use E. coli. I know from other lectures that they're using E. coli to produce this neurogenic growth factor for the cornea. It's not an antibody, but it's a neurogenic growth factor for neurotrophic keratitis. It works great. that comes into a packet. Got to train the patient. They train the patient, but it's 1 drop 6 times a day. So it's, you always hear them talking about 2, 6, 8, every 2 hours, 6 times a day for 8 weeks. It's has to come in glass bottles. It's very sensitive. That's a drawback to biologics, and that's why they're so expensive. And it's twisted up. It's why the vaccine for the coronavirus is frozen, because if you just shake it a little bit, it breaks apart. So that's the same thing with Oxervate, is that it can only be stacked so many high, and because it's very, very sensitive to being degraded. That's out there, and that's why, again, they're so expensive, because of all the precautions that they have to take. So some of the adverse events are, eye pain, inflammation, corneal deposits have been shown. Jumping over into sutureless amniotic membrane. I kind of shared this a little bit earlier, is that make sure you're doing cryopreserved, because on the infectious side, when you get to neurotrophic, it's not infectious. So, I'm okay with, if you want to go with a dehydrated on this, or, there's probably more healing properties in a cryopreserved that's out there. And that will produce the stem cell expansion, the pain suppression, promote cellular migration, and really help with recovery that's out there. So you decide on which condition, especially the infectious. You could make sure you use just to try to keep you out of problems if something ever goes south. Cryopreserve, when it comes to neurotrophic, you decide what you want to use on the patient. And this is just an example of a 67-year-old woman. She comes in with this neurotrophic ulcer. We decided to treat her with an amniotic membrane. There's without the stain. This is with the stain. And you can see we were able to heal her up with this neurotrophic keratitis. And when you literally did that cotton tip test, I was bouncing all over this, and she never felt a thing over this. So severe neurotrophic keratitis, you might need to do some surgical repair. Could be a penetrating keratoplasty. That was my patient I was telling you about, the hallucinations. And there's it's basically super glue, right? Cyanoacrylate glue, which is basically super glue that you can sometimes put on these corneas if they're perforating. But these are some really advanced procedures for severe neurotrophic keratitis. Hopefully we don't get them to that point. Now, the ocular findings associated with the herpes family, we talked about this slide earlier. Remember, there's vitritis, retinitis, and choroiditis. And you can see here's the iritis. There's, the dermatitis that can happen. But there are some retinal conditions that can occur with these conditions. And to kind of just round out and go quickly through this as we land this on time for an hour and 40 minutes, acute retinal necrosis here. It's a rare presentation of the herpetic or other viral disease. You can see now herpes simplex 1, 2, the cytomegalovirus, the Epstein-Barr virus is starting to come into play now. And remember, those are more in the lymphocyte type of coming in through the blood vessels. Characterized by large areas of whitening and necrosis. It is, was believed historically to affect healthy adults, but now it's basically people that have underlying immune dysfunctions. So the people that have an immune or immunosuppressed, those are the ones that typically get acute retinal necrosis. And you can use a polymerase chain reaction. Again, coronavirus has made that popular. You can take a small amount of aqueous or vitreal fluid and test the patient for this, for the acute retinal necrosis to figure out, is it herpes simplex 1, the cytomegalovirus, or the Epstein-Barr virus? So this is basically what acute retinal necrosis looks like in HIV or unaffected patients, herpes zoster is greater than 50%. But when you jump down into, the HIV patient, herpes zoster is 33%. So there's just, showing you, the different numbers. Either way, acute retinal necrosis, needs to be, in a sense, hospitalized with a retinologist. And then, there's progressive, you'll hear it called porn out there, progressive outer retinal necrosis. It starts in the posterior pole, then the outer retina. So we're starting in the posterior pole area, spreading out, where acute retinal necrosis is in the periphery first. And again, I'm just bringing these up and showing you pictures because you can see here, this needs to be hospitalized with a retinologist. They're getting acyclovir 2 grams, or they're getting intravenous or intravitreal injections. But I bring this up is because that is why the patient gets referred to you right from the primary care doc. When the patient sees zoster, they know that they're already immunocompromised. Is this patient getting, acute retinal necrosis? Are they getting that peripheral outer retinal necrosis that can affect them? And that's really what the PCP wants, because they know that these bad things can happen from these conditions. So the differential diagnosis, when you see, necrotizing retinitis, this is to help you out there. It could be syphilitic, it could be toxoplasmosis. I'm not going to read the whole list to you, going from sarcoid, down to Behçet's disease. But that's your differential diagnosis when you start seeing, retinal lesions, at least the ones that look like acute retinal necrosis that are out there. So with that, I'm going to launch polling question number 5. It looks like I was sharing that the whole time, so I apologize. And polling question number 5 is regarding herpetic eye infections. You feel more comfortable? You feel less comfortable after tonight? Or I'm going to treat the next one that I see. And I think I have this set up as multiple choice. So if you want to answer that question, that would be great. I'm hoping that no one feels that there's less comfortable. All right, checking out the chat. Joe, do we still have you out there? Or did we lose you to the tropical storm? Vanessa's on the other side of Florida, so she's okay. All right.
Say that it's upgraded to a hurricane, Greg.
Okay, gotcha. All right, so I'm going to just end the poll here. It's about 44 seconds in, and I'm glad that the majority of the people out there feel that it's more comfortable, and I'm going to treat my next one. That's the whole idea of doing these educations that are out there. So I just want to thank everyone. I see a thank you, Mary Ellen, so you're welcome. It's my pleasure. I want to thank everyone for showing up here tonight. Herpes A to Z. I hope you found it useful and helpful for your next patient experience.